Good afternoon, everyone. Thank you for joining us for our presentation today. We will be covering special incident reporting and updates to our regulations and reporting requirements. My name is Aaron Christian. I work for Mental Services. Just want to thank everyone for attending and getting information on the recent changes. Do want to thank everyone that had the opportunity to participate in the development of the regulatory updates and changes for their thoughts and feedbacks, as well as anyone who commented on the regulations package during the public comment period. So appreciate all of the thoughts and feedback on it. It really took a community effort to get to this point. So um, thank you for that. Before we jump into the presentation and we turn it over to the presenters, I do want to turn it over to our communications team who will go over some of the housekeeping items. So Jasmine, take it away.
Thank you, Erin. Hi, everyone. I'm Jasmine with the Community Engagement team at the department. And a few announcements before we begin. We're offering Spanish and Tagalog interpretation today, so I'm going to give instructions on how to access the Spanish and Tagalog channels. But first in Spanish. Para escuchar esta reunión en español, haga clic en el globo blanco en la parte inferior de la pantalla con la etiqueta Interpretation. Luego, haga clic en Spanish y seleccione Mute Original Audio. Rowena, can you please give instructions in Tagalog on how to join the Tagalog channel?
Audio. Para sa interpretasyon sa Tagalog, i-click lang ang puting globo na matatagpuan sa ibabang bahagi ng Zoom screen na may nakasulat na interpretation. Pagkatapos, i-click ang Tagalog at piliin ang i-mute ang original na audio.
Thank you. We're also offering ASL interpretation for today's meeting. The interpreters have been spotlighted and closed captioning is active. This meeting is also being recorded, and materials are available on the Risk Management and Mitigation page of the department's website. You may submit written comment via email to orm@dds.ca.gov. Next slide, please. Chat is not available, so please use the Q&A button to submit your questions. You may also use the raise hand button to ask a live question, and we will unmute you. Lastly, you can hover your mouse to the top of your screen to view the slides in English, Spanish, or Tagalog. Just select the slides you want to see. And that's it from me. Thank you. I pass it to Nathaniel.
Yeah, thank you so much, Jasmine. I'm going to circle back to Aaron real quick on some details as it relates to our YouTube viewers.
Yes, thanks, Nate. Just want to add for those that are just joining us, I want to clarify that our Zoom can only accommodate up to 1,000 participants. Being that we have a large volume of people participating, our overflow will automatically push people into YouTube Live, so you can live stream the presentation. However, with YouTube Live, we do have some limitations. You will not have the same question and answer feature that the Zoom participants will have. But in any event, just as Jasmine noted, if you have questions, comments, feedback on today's presentation, you can always send it to our dedicated Office of Risk Management email address, which is the acronym ORM, which stands for Office of Risk Management, at dds.ca.gov. So please feel free to send any questions or comments to that email address. For those that are able to view this within the Zoom link, you should see the Q&A function, and you can please feel free to make use of that and ask questions as we move along through the presentation. So thank you, and I'll pass it back to Nate.
Awesome. Thank you so much, Aaron. It's great to see everybody here today. As mentioned, my name is Nathaniel. Please call me Nate Talione. I'm the branch chief for the department's risk management branch. Before we get started, I'd like to briefly walk through today's agenda. Today we will primarily be providing an overview of the key changes and clarifications in the updated Title 17 Special Incident Reporting Regulations that are set to take effect May 1st, 2026. We will also briefly introduce resources available to support alignment which includes vendor special incident reporting guidelines, as well as training materials designed to help with implementation. We'll also leave time at the end of the presentation to address any questions that you all may have. Next slide, please. Thank you so much. Prior to going over the regulatory updates, it's always important to level set, and we must highlight the goal of today is to provide clarity and ensure all have the resources and support needed to ensure alignment with these regulatory updates. At its core, these regulatory updates are about strengthening our system to better support the individuals that we serve. This means making sure individuals receive the right services and supports at the right time, especially when something serious happens. It's also about using reporting to identify ways we can better support the service system as a whole, and not just reporting to incidents, but learning from them to improve how services are delivered. These updates are designed to strengthen partnership, bringing providers, regional centers, and the department into closer alignment with a shared understanding. Reporting is not about assigning fault, nor is it intended to be punitive. It is about understanding what happened, identifying risks, and supporting better outcomes moving forward. Reporting also helps us identify and mitigate risk earlier, so we can support both individuals that we serve and their families, providers proactively rather than reactively. At the department level, this information and data is used to identify trends across the system and across the state, highlight where things are going well, and identify areas that may need additional support, resources, or attention. And ultimately, reporting supports a system that learns, adapts, and continuously improves, a system that better supports everyone involved. As these regulatory updates take effect May 1st, 2026, the intent of these updates are to make significant strides towards each of these goals that I have listed and mentioned. With all that being said, I will go ahead and hand it over to my colleague, Leslie Morrison.
Hi, my name is Leslie Morrison. I'm a special consultant with the department, and I used to have Nate's position before Nate joined. So I'm delighted to be a part of this group and have been really integrally involved in the development of this Title 17 changes. Next slide, please. I do want to pause and say that we are aware that some individuals are having difficulty hearing. We are working to address that. For those of you that can hear me, I know that we're addressing it, and we are trying to get in touch with the folks that are having difficulty hearing the audio portion. All right, I'm going to go over an overview of the reporting requirements. I will highlight what has changed and what has remained the same. This first slide really has not changed in terms of what has been required as far as SIR reporting. Basically, vendors are required to report to the regional center with case management responsibility any special incident that occurs to an individual served, and we will be going over a list of those things that by Title 17 you're required to report to the regional center. Regional centers may have additional requirements that they alert vendors to, but these are what are required statewide by Title 17. That report needs to be filed initially to the regional center within 24 hours of learning of an incident, and there must be a written report filed to the regional center within 48 hours after learning of the incident. If the regional center with case management responsibility is different than the vendoring regional center, then special incident reports must be filed to both regional centers, the regional center with case management responsibility and the regional center that is the vendoring regional center. Again, this is not any change in practice from what has been previously required. Next slide, please. There are generally two categories of incidents that must be reported to regional centers. One are special incidents that must be reported for any individual served, and another is a group that only needs to be reported if the individual is under vendored care at the time of the incident. So 2 general categories. Again, this is no different than what has previously been required. Things that must be recorded or reported for anyone served, there are 3 categories. One is any death. So any death that occurs, whether it occurs at a time an individual is receiving vendored services, must be reported. Secondly, any time an individual is a victim of a crime, that must be reported. And again, that must be reported whether the person was considered under vendored care at the time. There is a new reporting category, and this also is for anyone served, and that is when a mandated abuse or neglect report is filed with Adult Protective Services, Child Protective Services, the Long-Term Care Ombudsman, or law enforcement. If a vendor makes any mandated abuse report to any of those abuse response entities, then they must now also file a special incident report with the regional center. That is a change, and again, that applies regardless of whether the incident occurred or the report was filed when the person was under vendored care or receiving services at the time. So those are the 3 categories covered. They're considered universal reporting requirements. And again, those are death, anytime an individual is a victim of a crime, and anytime a mandated abuse report has been filed. Otherwise, all of the other incident reports only need to be filed if the person was considered under vendored care at the time of the incident. And we'll go into that much more detail in the coming slides. Next slide, please. Okay, when is a person considered under vendored care? An individual is considered under vendor care when any of the 4 apply. First, a person is considered under vendor care if the vendor is providing services or supports to the individual at the time of the incident. A person is also considered to be under vendored care if the vendor is listed in the individual's IPP as being responsible for providing services and supports at the time of the incident. So if they're in the IPP as being responsible for providing services at the time, they're considered under vendor care. A person is also considered under vendor care when a vendor is responsible for providing services and supports 24 hours a day, 7 days a week. Or if a vendor is required to provide 24/7 services under the California Code of Regulations. So we're going to spend a minute talking about which service providers are considered to be providing 24/7 care. Service providers that provide 24/7 care include long-term healthcare facilities like ICFs and skilled nursing facilities, supported living services providers, family home agencies, financial management services, and any residential service provider. So again, those service providers are considered to be providing 24/7 care, and incidents must be reported regarding individuals they serve, even if the individual is not under their care at the time. They're considered 24/7 providers, and the individual is always considered to be under their care. And so therefore, any incident that occurred to the individual must be reported. Next slide, please. So now we're going to talk about some of the key changes in Title 17. One of the biggest changes is all of the terms have been defined. So this is different from Title 17 previously, and we really encourage you to either check Title 17 or check the guidelines that DDS has posted to really help explain what terms mean. But all of the terms that are used have been defined. For example, medical treatment beyond first aid, hospitalization, serious injury, all of those abuse, physical restraint, all of those terms have been defined, and you should refer to Title 17 or the guidelines to help you understand what those terms mean. So, as I said, anytime an individual is the victim of a crime, any crime, whether they're under vendor care at the time or not, a special incident report must be filed. So if, as a vendor, you learn that an individual was likely the victim of a crime, you have to report that incident, even if they were not under your care at the time. The list of crimes previously was about 5 or 6 crimes, but vendors have always been required to report any time an individual is the victim of a crime. The changes to Title 17 added a more robust list of crimes that include simple assault, battery, fraud, identity or credit theft, attempted or actual homicide or manslaughter, human trafficking, stalking, and hate crime. So those crimes have been specifically added to encourage folks to think beyond these crimes that were initially recorded or listed. But anytime you think an individual has been the victim of a crime, you have to complete a special incident report and submit it to the regional center. Next slide, please. The next category of incidents that have to be reported when someone is under vendor care is when there has been an incident of reasonably suspected abuse. This is not a new category. This is a category that's existed before, and we have always been required to report incidents, any incident of reasonably suspected abuse. But the new Title 17 guidelines requirements have listed additional examples of incidents of abuse beyond those that were listed previously. Fiduciary abuse was required previously, and the new Title 17 regulations have changed that to financial abuse. So any incident of financial abuse must be reported. Fiduciary abuse requires a specific relationship between the individual who committed the abuse and the victim. This has now been expanded to any financial abuse and does not require that fiduciary relationship. In addition, other categories of abuse that have been included in the list are exploitation, verbal abuse, isolation, restraint use, and again, anytime an incident of abuse has been filed with protective services. When we look at isolation, again, the term for isolation has been defined in Title 17, and it is distinguished from seclusion. Seclusion is prohibited for anyone with an intellectual or a developmental disability. Therefore, if an individual with a developmental disability or intellectual disability has been put in seclusion, that is considered abuse, and any use of seclusion should be filed as an incident of reasonably suspected abuse. And again, the new Title 17 requirements distinguish isolation from seclusion. The other category under abuse is the abusive use of restraint. And this category existed under the previous Title 17 requirements. These requirements provide a little more specificity about what is considered the abusive use of restraint. Specifically, you have to file a reasonably suspected abuse report if the restraint techniques used are inconsistent with the program's approved plan, restraint training program, or restraint policy. So for programs whose program plan permits them to use restraint, any use of restraint that is inconsistent with their approved plan or their training curriculum or their restraint policy would be considered abuse. It is also reasonably suspected abusive restraint use when physical, mechanical, or chemical restraint is used when the individual's behavior does not pose an imminent risk of harm. It is also considered the abusive use of restraint when restraint is part of an individual's IPP, but the restraint technique used was not approved in that individual's plan. And lastly, it is considered abusive use of restraint when chemical or mechanical restraint are used inconsistent with a physician's order. So any of these are considered reasonably suspected abuse and should be reported. Again, these are only for when an individual is considered under vendored care. The regulations also do add this category about an incident reported to protective services. But again, that is a universal reporting requirement and does not pertain only to people under vendor care, but to any individual served if an incident of abuse or neglect is filed with any of those abuse response entities. A special incident report must be filed. Next slide, please. The next category of special incidents is reasonably suspected neglect. And as with abuse, Title 17 required any incident of reasonably suspected neglect needed to be reported. The changes to Title 17 add a few more examples or a list of what might be considered reasonably suspected neglect. But again, any incident of reasonably suspected neglect must be reported. The additional categories that were added: one is the failure to provide medical or dental care for the physical or mental health needs of the individual. That has always been in Title 17, but what was added specifically is including failing to administer required health interventions. So if an individual was required to have a specific health intervention, like the application of compression hose, and those hose were not applied, that would be considered reasonably suspected neglect. It's also reasonably suspected neglect when a provider fails to protect against health and safety hazards. That is an existing reporting category, but what has been added here is including failing to prevent 2 or more falls in a 30-day period. So 30 days, meaning not just every month, but 30 calendar days. If an individual has 2 or more falls in 30 calendar days, that must be reported. Even if they have a fall prevention policy, if you have 2 or more falls in a 30-day period, that needs to be reported as reasonably suspected neglect. If the fall is from a health and safety hazard and is considered failing to protect from the health and safety hazard. So my example here is I ride my bike. I am a bicycle rider, and I have 2 falls off of my bicycle that are not considered to be failing to protect from a health and safety hazard, but my clumsy bicycle riding behavior, then that would not fall under this category. The next category under reasonably suspected neglect is failing to assist with personal hygiene. Again, this is an existing reporting category. That includes failing to assist with toileting, incontinence needs, and the provision of fluids. This has been added from what was previously required in Title 17 about failing to assist with personal hygiene. The category of abandonment has been added. So failing, causing abandonment, that is considered reasonably suspected neglect, and that must be reported. And then here again, anytime you file a report with a protective agency under the Mandated Abuse Reporting Act, you also need to file a special incident report. And again, that is whether the individual is under vendor care at the time or not. When you file an incident report under your mandated abuse reporting obligations, you also have to file a special incident report. Next slide, please. The category of serious injury accident, this is an existing category. You have to file a report when an individual has been had any sort of a serious injury or accident. That has not changed. Any serious injury or accident has always been needed to be reported. However, additional categories have been added. So the first category, lacerations, have always been a reportable category. What was added here was lacerations requiring wound adhesives or other closure beyond first aid. As you know, many wounds are closed these days, not using staples or sutures, but in fact using wound closure devices, and so that has been added. Also added is any injury from a seizure that requires medical treatment beyond first aid. And on this slide, you can see that we've provided you with the definition of medical treatment beyond first aid. Medical treatment beyond first aid means when an individual served receives treatment by a trained medical professional beyond the one-time short-term treatment administered immediately after the injury occurs and at the location where it occurred. So when an individual is at a residential setting and they fall and sustain an injury from a seizure, if the staff at the residential facility cleaned the wound, apply a Band-Aid, that is not considered medical treatment beyond first aid. That would not be reportable. But if the individual is subsequently sent to urgent care or is seen by their physician, then that would be considered medical treatment beyond first aid. Another new reporting category is any bruising, contusions, or hematomas to the eyes, head, or neck, regardless of the size. Any bruising, contusions, or hematomas to the breast, genitals, rectal, or anal area, regardless of the size. Or any bruise, contusion, or hematoma that's 2 inches or larger in size. So these are required to be reported. The bruising to the head, eyes, neck, breast, genitals, and rectal area, those are very vulnerable areas and areas where it could suggest possible abuse or neglect. So those bruising to those areas require reporting regardless of the size. Otherwise, only bruises that are 2 inches or larger to other areas, for example, the thigh or the lower leg, the buttocks, perhaps might not necessarily require reporting unless it's 2 inches or larger. Any serious injury or accident that results from aggressive contact with another individual that requires medical treatment beyond first aid, that must be reported. Again, this is aggressive contact between 2 individuals served. So when one individual served engages in aggressive contact with another individual served, and one of them requires medical treatment beyond first aid, then that must be reported. Any head injury, including a concussion, that requires medical attention, and the regulations distinguish medical treatment beyond first aid from medical attention. Medical attention means when an individual served is assessed and or under the observation of a trained medical professional, but doesn't necessarily require medical treatment. And this is because often head injuries do not require medical treatment. Often individuals are monitored for a period of time, but don't necessarily receive any medical treatment. They're under the observation to see if they have a concussion or other kind of head injury, but don't necessarily require medical treatment. So any head injury, including a concussion, that requires medical attention must be reported. And then finally, any pressure injuries that are stage 2 or greater or unstageable, that must be reported. Next slide, please. The other 2 new reporting categories are any emergency room visits where the stay in the hospital emergency room is for 5 days or longer. So we do not know that some of our individuals do end up staying in the emergency room for long periods of time, for days on end, and anytime an individual is in an emergency room for 5 days or more, that must be reported. We also have a category of unplanned or unscheduled hospitalizations. Under this, only certain hospitalizations must be reported. Those are for certain conditions. And the new condition that has been added here is any unplanned or unscheduled hospitalization for a bowel obstruction. So that is a new reporting category in addition to the previous reporting categories. A SIRMUS is required when the vendor learns that the hospitalization is related to a reportable condition. Don't wait for discharge paperwork or a final discharge diagnosis. Anytime you learn that an individual has been hospitalized for any of the conditions that must be reported under Title 17, that should be reported. Next slide, please. I know we have a number of questions and we'll get to them as quickly as we can, but I just want to let you know that we have a number of training materials and reference materials available. We have the vendor SIR reporting guidelines. This is a really great reference document that the department put together. It's online, and this is a hot link on this PowerPoint. Nate will also put in the chat, I think, the link to the vendor reporting guidelines, but this is a great reference document. So if you have any questions about whether it needs to be reported or not, please use this document. I would encourage you to also read it cover to cover, but it is rather lengthy and it's intended to be a reference document. We also have training videos that we are putting up on our website. They are short, about 5 to 7 minute animated clips that really dive into each of these different reporting requirements. They are in English and are being translated for vendors into Spanish and Tagalog. And those are coming online in batches. So hopefully all of those will be posted in the next month or so. We are also finalizing a frequently asked questions document, and we'll be using some of your questions here today to be sure that we've covered all of those frequently asked questions. That will also be available in our website. And then, as you know, we are now doing trainings, for example, as this training is happening, so that you can ask any of your questions and we can provide you with direct information. Last slide, please. If you have any questions about any of this, please do not hesitate to email us at orm@dds.ca.gov. Again, that's orm@dds.ca.gov. These new Title 17 reporting requirements go into effect on May 1st. So giving you plenty of time to get up to speed, ask your questions, before we have the official go live on May 1st. I think that it concludes our formal presentation, but I know we have a number of questions, so perhaps we should turn to some of those.
Yeah, Leslie, I think a good place to start is questions we received as it relates to being under vendor care. So maybe go over some of those parameters, and I'll provide the link to the page number of where that's covered in the guidelines too.
Certainly, and if we could return to slide number, I think it's slide number 6. Nope, it's slide number 7, my apologies. Nope. Slide number 8, sorry. Slide number 8. So an individual is considered under vendor care when any of the following apply. One is a vendor is actually providing services at the time of the incident. Then an individual is considered under vendor care. An individual is also considered under vendor care when a vendor is listed in the IPP as being responsible for providing services at the time. So an example is an individual was to be transported to their employment site by a transportation vendor. And an incident occurred at the time would be considered reportable. If the transportation vendor was to be providing services and supports at that time. An individual is considered always under vendor care when they are receiving 24/7 supports, or whether a vendor is required to be providing 24/7 services and supports under regulation. And the service providers that are considered to be providing 24/7 services and supports are long-term healthcare facilities, residential facilities, supported living service providers, family home agencies, and financial management services providers. So, for example, if an individual is receiving supported living services, but an incident happens when the SLS worker is not present at the time, that incident is still considered to be reportable because SLS, as a provider, is considered to be providing 24/7. Even if a staff member was not present at the time, SLS is considered a 24/7 service provider. I also want to say that it isn't just the responsibility of the vendor providing services at the time. So if a incident happens on a transportation by a transportation service provider, and that incident is discovered by a residential services provider, the residential services provider should report the incident that they knew occurred when the individual was getting transportation services. So you do not need to report it only if it was under your vendor care. But if you knew the individual was under the vendor care of another vendor at the time, then it should be reported. I'm hoping that that answers that question, Nate.
Yeah, for further details, and we have some key issues that explain and provide some examples as it relates to being under vendor care. Please refer to the vendor special incident reporting guidelines. Link is in the chat. And this particular section begins on page 16. But as Leslie mentioned, we encourage everyone to read it cover to cover. We acknowledge and recognize it's a little long, but a lot of useful and great information.
Other questions? I know we had some. Go ahead, Nate.
Yeah, I'm cycling through some of them. One of them has to do with what if an individual served has self-injurious behaviors? Do we need to file an SIR?
No, not according to Title 17. Self-injurious behavior is not reportable as required by Title 17, but your regional center may have additional incidents that they require you to report as a vendor. So this is the baseline. This is the floor about what is required under Title 17, but regional centers may require you as a vendor to their individuals to require incidents above and beyond this list. So I would be sure to loop back to your regional center to see what additional incidents they may require you to report beyond these changes in Title 17.
To piggyback off of that, there was a question as it relates to a form to report all of the following are the items we're going over. As Leslie had mentioned, regional centers do require different layers of special incident reporting. And so we would direct that question back to the regional center as well.
I would just say that we have provided in-depth training to the regional centers, and it is our understanding that the regional centers are updating all of their processes and forms to be sure that they are up to date and ready to be implemented in advance of the May 1st start date. So I would expect you could see updated forms, but again, that is on the regional center, not from DDS.
Another question.
Go ahead, Nate.
Another question as it relates to early start. Toddlers frequently trip, fall, and get bruises and scrapes. Do we report every incident?
So no, we're not going to have you report every incident. The broad umbrella here is reasonably suspected neglect. So if you reasonably suspect that these falls, these multiple falls that are occurring, are related to failing to protect the toddler from health and safety hazards, then yes, they would be reported. But we certainly know that individuals, in addition to toddlers, do at times have falls issues. So the overarching umbrella first is whether or not it's related to reasonably suspected neglect for failing to protect from a health and safety. So first, you kind of need to give it that thought. You could imagine that there may be situations where toddlers continuing to fall might start feeling a little bit more like reasonably suspected neglect, but it has to first meet that threshold.
Some other questions as it relates to ER visits. So maybe if we can go over some of that information again, and maybe perhaps provide a little bit more detail.
So every ER visit is not required to be reported. Only emergency room visits that last 5 days or more. And again, this may vary by regional center. So some regional centers may in fact require vendors to report every ER visit. Title 17 does not require that all ER visits be reported, only those that last 5 or more days. And I did see a question in the chat about what if you find out about that later on. Title 17 always requires that you report things that you learn of, even if they happen a while ago. So if you learn of an ER visit that lasted 5 days or more, and you learned that that ER visit happened a month ago, you still need to report it. Just like if you learn that an individual passed away and they passed away a month ago, you report it as soon as you learn about it. So the amount of time that lapsed doesn't matter. You have to report it as soon as you learn about it.
Also getting some questions on do urgent care visits need to be reported too?
Again, urgent care visits do not need to be reported. I start thinking about that serious injury accident category and whether the individual's serious injury or accident required medical treatment beyond first aid. So it's not the urgent care visit that might need to be reported universally, but it would go to the injury or accident and the injury that the individual sustained and whether that required reporting when the individual got medical treatment beyond first aid. Again, some regional centers may require you to report all urgent care visits, but Title 17 as a floor does not require every urgent care visit to be reported.
Another question as it relates to emergency room visits or hospitalizations. So this one is if I'm providing care for a patient and they casually mention that they were hospitalized a month ago for more than 5 days, must I report when I learned about it?
Certainly, any hospitalization for a reportable condition must be reported. So it's not every hospitalization, it's only a hospitalization for a reportable condition. Those include respiratory conditions, cardiac conditions, I don't recall all of them. Those conditions have not changed. All of the ones that were previous, I think a diabetes related, all of those must be reported, even if they occurred a while ago. Any hospitalization for a reportable condition must be reported, regardless of how long the individual stays in the hospital. So the 5-day period only pertains to emergency room visits. Any hospitalization for a reportable condition must be reported, regardless of how long that hospitalization lasted. Unplanned involuntary psych hospitalizations is another example of a hospitalization that must be reported. But the 5 days only tracks to when the individual is in an emergency room. I
Good
do see a question.
on-
I do see a question here about pregnancy. Pregnancy is not specifically listed, but the department's approach has always been that any pregnancy is reportable either as suspected abuse or neglect. So any pregnancy of an adult or a minor needs to be reported, and it's reported as either reasonably suspected abuse or neglect. Sorry, Nate.
It's fine. Quick question on sending special incident reports. Are we still sending via fax? Regulations have been updated that allow for electronic submission or fax. We would encourage you to contact your regional center to see what is the most appropriate process of submission. And it looks like the rest of the questions are all individualized, and so we can kind of start running through them one by one. What do you think, Leslie?
Yes, I'm delighted that you guys have so many questions. And again, if you don't feel like we have adequately addressed your questions, please refer to that vendor reporting guidelines. It is an excellent reference document. I think it really covers all of the possible questions we anticipated you might have. But please also feel free to reach out to orm@dds.ca.gov if you have additional questions. As I said, your regional centers have also been trained, and so they are a resource for you as well.
So one question that we received was related to training certificates. For this training today, that does not be done for today's training. So just to answer that question, more of an admin question about this training itself. I'll go ahead and jump to the top of these question lists in the Q&A. Do we call 911 for every fall since we are not medically trained? And I believe you covered a little bit of this, but if you wanted to expand a little bit more.
You know, we are really covering what is required in terms of reporting special incidents. I would refer to your vendor's policy about whether, as an agency, they require you to call 911 for every fall. That is not something that the department requires. What we're really talking about here is unusual incidents or special incidents that must be reported to the department. I think it's a good question, but I would refer to your employer, your vendor agency, about whether it is your policy that you call 911 for every fall. That's not something that the department has we do not have a requirement that happen. The last thing I want to just say as we come to a conclusion is, again, to really emphasize what Nate said at the beginning, which is the purpose of special incident reporting is to not catch vendors doing anything wrong. We really want to make sure that the individual served, that we can quickly respond to unusual occurrences, special incidents that are happening to them, and be sure that they are getting the services and supports that they need, that their IPP is addressing all of the issues that they are having. It also helps us take a look at the service delivery system across the state. And if we were seeing a particular pattern of incidents occurring, it gives us the opportunity to develop additional services and supports for our community. So it really is important that these incidents get reported. It is really so that we can provide the best services we can to individuals as needs change. It is not about catching anyone doing anything wrong. It's about ensuring that our individuals are getting the services and supports they need, either individually or across the service delivery system. And your reporting to us is the best way for us to be able to make sure that we're giving the individuals we serve the services and supports that they need. It's coming from that place. So as you think about incident reporting, think about it from that perspective and making sure that the individuals are getting what they need and that the department is offering an array of services that meets the needs of our population.
Getting an influx of questions related to hospitalization. So we really encourage everyone to look at unplanned medical hospitalizations reporting within the vendor SIR reporting guidelines. It begins on page 37. It outlines when reporting is required.
I'm quickly pulling up Title 17 to just go over what hospitalizations must be reported, since we didn't have that on the slide. So I'll just go over that again. This has not changed from previous reporting requirements. The only hospitalizations, unplanned, unscheduled hospitalizations that must be reported are hospitalizations for respiratory illness, including asthma, tuberculosis, and COPD. Unplanned or unscheduled seizure-related hospitalizations, cardiac hospitalizations, infectious internal infections, diabetes, wound care, nutritional deficits, involuntary psych hospitalizations, and also any hospitalization for a bowel obstruction. So hospitalization is one of those categories when you only need to report for individuals under vendor care, and only when their hospitalization is for one of those conditions. So again, look at our vendor reporting guidelines. It lists those conditions, but you only need to report unplanned or unscheduled hospitalizations for those conditions.
The question that we often receive: if a incident occurs while an individual is at a day program or out of like the home, is the home still required to file an SIR?
Residential service providers are considered 24/7 providers. So even an incident that occurred when the individual was not at the residence, if they were under vendor care at the time, then the residential service provider has to make that report. So if the individual is at their work site with an employment coach and an incident happens there, and the residential service provider learns about it, and it occurred when they were receiving services by that employment services vendor, then yes, the residential service provider needs to report it. The employment services provider may also report it, and the regional center will collapse those two reports because they are reporting the same incident. But yes, if the residential service provider learns about it, they have to report it, even if it did not occur while they were under their vendor care. I do believe that the slides will be made available, Nate. Is that correct?
Correct. Currently, the slides are available within the registration link that was emailed out. We have it available on the DDS events calendar, as well as available on the department's risk management website under trainings.
We do have a question about self-neglect, and I wanted to address that. Self-neglect is considered reportable. So it's not just neglect by a service provider or someone for whom the is responsible for providing care and services, but self-neglect is a reportable event, and it's the same thing. Any incident of self-neglect must be reported. And the same applies for self-neglect under the Mandated Abuse Reporting Acts. So any self-neglect that's reported to a mandated abuse reporting entity needs to be reported as an SIR to DDS or to the regional center. I know that we're coming close to time. I don't know if folks have other questions. Nate, I know we have this identical training happening later in a few weeks, and we can let folks know about that. It is the same training that we've provided, but if you want a refresher, please feel free to join that training as well. Nate, do you remember when that training is?
Yeah, the training is scheduled for April 1st. It is at 9:30 a.m. We wanted to have one of these trainings in the afternoon and another training in the morning, so it could be available for folks. But yeah, April 1st at 9:30. The registration is available on the DDS website and the calendar for registration links. Registration links is also available on the department's risk management page that I just put into our chat.
I see a question here about an incident happening when with family. This is really very much incident specific, and it also depends upon the vendor. So generally, when an individual is with their family, they're not considered to be under vendor care unless they meet some of those under vendor care requirements. So for example, if they are served by a family home agency and they are on a vacation with their family from the family home agency, the FHA is considered a 24/7 provider. So even if an incident happened while the individual is with their natural family, but they are served by an FHA, the FHA has to report it. Similarly, if they were the victim of a crime, or if a mandated abuse report was filed when they were with the family, those are universally required to be reported. So those would need to be reported even if they occurred when they were with the family, because those are among the incidents that are considered universal and must be reported. So when an individual is on a home visit with the family and passes away of natural causes, that would be a reportable event. If they're with the family and a victim of a crime, that would need to be reported because those are universally required to be reported. That is not specific to whether they are under vendor care. Similarly, if a school reports, you learn that a school filed a child abuse report against the family for a child served, that would be a special incident report because it was a mandated abuse report involving an individual served, even if they were not under vendor care at the time. So those are the three incidents of things that must be reported, whether they were under vendor care at the time or not. We have questions here about the bruise, how the bruise occurred is not contingent on whether it gets reported or not. The size of the bruise and the location of the bruise is what is important. Again, bruising to the head, eyes, neck, breast, genitals, or rectal area, that needs to be reported. Any bruising to those areas, regardless of the size, and any bruising that's 2 inches or greater, any place else must be reported. Certainly, when you have bruising to some of these suspicious areas, we encourage you to think about whether it could be a possible abuse or neglect situation, and you may need to also report that as reasonably suspected abuse or neglect. If you don't know how that bruise occurred and you think it might be the result of abuse or neglect. But how an individual receives the bruise is not what is required. It is about the size of the bruise and where the bruise occurred. I believe the definition of self-neglect is in the reporting guidelines. I encourage you to take a look at those reporting guidelines for some of those definitions. Again, when you have a question about how a term is defined, really encourage you to look at those reporting guidelines. They're pretty exhaustive. SLS is considered 24/7 service provider, even if they only provide services intermittently and sporadically. SLS is considered a 24/7 service provider. So if you provide services 4 hours a day, 2 days a week, and an incident happens outside of that time, they are still considered under SLS, even if the SLS provider was not there at the time, and an incident must be reported.
So a question on what's FHA? It's Family Home Agency.
And again, I have a question here about a bruising after a mammogram. If the bruise is to the breast, it needs to be reported. You might include in your incident report that they did have a mammogram, but it is not about the cause. It is about where the bruise occurred. So if there was a bruise to the breast, it needs to be reported regardless of the size. But you might want to offer in that incident report the additional information that they had received a mammogram.
We have a question in the chat. If an FMS is a 24/7 vendor,
Yes, an FMS vendor is considered a 24/7 vendor. So when an FMS learns of an incident, they must file a report. Well, I want to thank you all for your participation and your thoughtful questions. This can be tricky and confusing, so again, encourage you to look at those reporting guidelines. Happy to answer questions that you have, email them to ORM. But first go to those reporting guidelines because that is a reference document. I think it's a great document to use as a resource. It's intended to be used as a resource. So you can get those questions answered and become familiar with looking at it as questions come up over the course of when you're providing services and supports to our individuals.
awesome. Thank you so much.